Okay. Let's cover eye disorders first, starting with blindness. Now, for blindness, the only thing we will test is the age-related blindness. So let's start with presbyopia. What is it? So this is age-related blindness. So a patient gradually loses sight and then they are eventually declared legally blind. So this is different from what we'll cover later, which is macular degeneration. That's another disorder. So presbyopia, there is no disease to speak of here. The eyes just went blind. Okay? The patient got old and then developed presbyopia. Management is just to preserve what remaining vision the patient has, as simple as that. Meanwhile, nursing care would focus on what could happen to you if you can't see. Okay, so it's all about safety, correct? So we depend on our vision to remain safe, to be able to do ADLs, to get around, work, take care of ourselves and our families, and enjoy life. Once that vision is gone, safety is the number one concern. You could get hurt, you could get killed. We look at the nursing care at the end of the chapter. That's where it's found. We will talk about cataracts, macular degeneration in the next few pages. Here are some aids that the doctor will prescribe to the patient with presbyopia or for any patient any other patient who has vision impairment. We also have adaptive applications on our phones. You may not be aware of it because you're not needing it because you don't, you're not vision impaired, so you're not aware of the features on your smartphones that allow vision impaired patients to still use the phone, and even apps that help them get around. Yes, boys. Here is in general. So this one will be referred to back again when we talk about macular degeneration or retinal disorders, for instance. So they will refer back to chart 58-4. Okay. So is this a good select all that apply question? Sure. Yes. So these are principles we must follow whenever we take care of vision impaired patients. So when you enter the room, do you just enter and then touch the patient directly? Yeah. Okay, so you have to announce your presence, correct? So announce that you're entering the room, not go in there and then suddenly just touch the patient. You could give them a heart attack. I won't read it for you. Please read on your own. Any questions on vision impairment? Oh, blindness, presbyopia. Okay. Part of your responsibilities are administering eye medications. Now, eye medications can be in the form of eye drops, which are thin liquids, or eye ointments, which are based on petroleum. So they have a waxy, you know what ointments are, right? So the base component is wax or petroleum, and then they added medications to it. Okay, mostly water, glycerin, that kind of stuff. So there are two sets of charts we will follow here in order to administer these medications, and some rationales also for why certain actions are done. Okay, why we wait, for instance, a certain number of times, certain amount of time before giving a second eye drop, for instance, and why we give eye drops first before eye ointments, okay? So here are a few facts which will help you answer or make sense of our actions on administration of eye drops. For instance, this first bullet here. So when you apply eye drops, do you apply them one after the other? How long do you wait between administration of the same eye drop to the same eyeball? It's about at least 1 minute. Okay, so this is the rationale. The eye sac, which is the part of the eye that contains blood vessels, and so this is the part of the eye where you administer the eye drops. That way you have absorption of the medication. It can only hold 50 microliters. So therefore, if you administer more than one eye drop is about 20 to 35 microliters. So therefore, if you apply more than one drop at a time, what will happen to the second drop? It will just wash out. It will just drain out of the conjunctival sac, because the sac can only hold how much? 50 microliters maximum. So you have to wait until the medication is absorbed, and then you can apply another dose of the eye drop. Clear? So again, the medication will just either run down the patient's face or drain into the lacrimal duct and into the nasal passage. Okay, so you're wasting the medication. Meanwhile, the patient's not getting the medication. So therefore, if that medication was to prevent blindness, then guess what happens to the patient? They go blind. And this is also another thing to consider. So when we apply eye drops or ointments, for instance, it will automatically trigger tearing, blinking, and drainage. So this is a protective response by the eye structures. So whenever something, any debris, wet, solid, or even air, gaseous materials, when it enters the or when the eyeball is exposed to it, it automatically triggers tear production. Then you automatically blink, and there will be increased drainage of the liquid, right? So consider these whenever you administer medications. Will these ever disappear? No, because, well, it will, so therefore, after 10 years of administering eye drops, there will no longer be tearing, blinking, or drainage. Well, you get used to it, but doesn't mean that these responses disappear or stop happening. They will always be present. Okay, no matter if you've been taking the eye drops for 50 years or 100 years. Okay? You can't get rid of the responses. Okay, these are reflexes. Okay. Okay, let's go now to the medications. So we've got, please be familiar with the terms. We've got mediatic and cyclopedic agents, although this chart here are not what we're testing because they're not specifically mentioning for which eye disorder they're given to, but just know and be familiar with these drugs. For instance, the ones I highlighted here are atropine and phenylephrine. Now, because of the nature of the drug, what is atropine? It is a anticholinergic. So what do all anticholinergics do? Increase heart rate. What else? Okay, they cause dryness. So how do they dry stuff? By causing water retention, correct? Okay, so, and they therefore cause blurring of vision, not only increasing pressure in the eye, but everywhere else. There will be water retention everywhere else. Okay, there will be urinary retention. What about phenylephrine? So what is this drug? This is not only in eye drops. This is a main ingredient in Sudafed. So your nasal decongestants, how do they open your nasal passages? By doing what to the blood vessel? Dilating. Actually, it causes bronchodilation through how? Vasoconstriction. Okay, very good. So therefore, what does it do to blood pressure? Increases blood pressure. So that's your main side effect of phenylephrine. And we can also give steroids to the eyes, anti-inflammatory, and mentioned earlier were antibiotics. They again come in either eye drops form, which is thin liquids, or in ointments. Let's go to these steps now. Now, it's important to do the proper teaching to the patient. That way they get the benefit of the drug, and that they get treatment for what it is intended for. Now, if you take time to just observe patients administer their own eye drops, so you'll see a very good teaching moment wherein you'll see, oh, no wonder why this patient's going blind. They're not doing it correctly. All right, so I bet you 5 times out of 10, this is what's happening. Okay. So the last patient I observed administered their own eye drops. She just did this. So she opened the bottle because she insisted, no, I'll do it myself. And then she just did this. No, nothing even came out. Because, I mean, how do you administer eye drops like this? Right? So I said, okay, so that was a very good teaching moment. And then she says, oh, nobody told me that. She swore nobody taught her how to administer eye drops. She just thought it was that way. Now, I said earlier, it's 1 minute. You wait 1 minute between drops or administration of the same medication. Now, if it's a different medication, meaning you have one eye drop and then another eye drop is prescribed, you should wait how long? It's gonna have to be 5 minutes. So we wait until the previous drug is fully absorbed before we administer a different drug. Now, can this be a challenge? So let's say you end up in a nursing home wherein you have several glaucoma patients, and each patient will have 2 or 3 eye drops to be given. Do you have that time? So what are you tempted to do? And are you giving them to the patients correctly? Are they getting and absorbing the medications? No. So you have to be just creative. So let's say you're in a hurry, you have 40 patients to give medications to. Why not administer now? And then while waiting, you administer the 1 eye drop now, and then you administer PO or IV sub-Q, and then come back to the eye again, after the administration of the oral, give the second medication. And then you can even go, let's say it's a different medication, right? So you have 5 minutes. So you can close that patient's chart, go to the next patient first, right? Administer that second patient's medications, and then come back to the patient to finish the eye drops. All right. So yes, you're busy, but please make sure the patient gets their medications properly. All right. You're the nurse. They depend on you. First disorder is glaucoma. There are many forms of glaucoma. All of them, though, have one common problem, which is an increase in intraocular pressure. There are many ways by which they develop, but they all end up in increased intraocular pressure. When that happens, then once the pressure in the eyeball increases, what happens to the blood vessels and nerves supplying the eyeball? they get compressed, right? There's ischemia, and then what happens to the tissues around the eye? They deteriorate, they go ischemic, and then they die. Patient goes blind. Here's the chart. They put it here, so let's discuss it now. Hand hygiene. The tip of the medication container should never touch eyelashes or eyelids. Okay. Hold the eyelid down, and where do we administer the drop again? In the lower conjunctival sac. Okay, not on the eyeball. The eyeball has no blood vessels because it's covered by lens. So it's protected by the lens. So if we put medication there, nothing will get absorbed unless you remove the lens. If it's an ointment, like I said earlier, so if the patient receives an ointment, give the eye drops first and then an ointment. An ointment will be applied this way. So you go from either left to right, depending on if you're right or left-handed, but apply a thin ribbon of the ointment, again, on the same place on the lower conjunctival sac. And whether you're giving an eye drop or an ointment, always apply gentle pressure where? In the inner canthus. Okay. It's also called the punctum. So terms interchangeably used on exams is either punctal occlusion or the putting pressure on the inner canthus. And give them a tissue to blot out any excess, because there will be, again, like as I mentioned earlier, there will be increased tearing and drainage from the eye. So 5 minutes before giving a different eye drop, and then if it's an ointment, 10 minutes before giving a different ointment. Are we clear? Any questions? Okay. Okay, let's continue with the reason why the eye drops are placed here is because glaucoma treatment will involve 3 or more eye drops administration for life. So depending on how old the patient was diagnosed, we do get young children diagnosed as early as 6, 7 years old, because that's really when they get regular eye checkups, right? So in school, the children are, if they go to public school especially, so they have regular checkups, correct? The school nurse does the basic eye exams, and that's really when people get diagnosed. So school age children. And the treatment again is for life. So they'll start at 6, 7 years old, and then if they have glaucoma, the only treatment again is eye drops. So they will be using these eye drops until the day they die. Yes, sir. Can also that's part of the treatment, but the eye drops already involve beta blockers. Yes. There are surgical options, but they're not very popular. Although some are successful, but not really applicable to most patients. It's only because surgeries are only optional for certain types of glaucoma. So what happens in glaucoma? Again, the mechanism here can vary, but all of them have one thing in common. So either the aqueous humor production. What is aqueous humor again? This is the liquid that is contained in your eyeball. So if you stab your eyeball, the liquid that comes out is called aqueous humor, right? So that's the liquid that gives your eyeball its round shape. It's constantly produced and drained. So the problem here is if there's an imbalance between the two. So either the patient's aqueous humor production increases while drainage remains the same, or it's the other way around. Production may be steady, however, the drainage is decreased because there's obstruction in one or more places of angle. Okay, let's when you see a mention here about the word angle, it's really referring to, let me go back a previous page to the anatomy. When they say angle, it's really referring to these right here. So you see the canal of Schlemm, the ciliary body. Okay, so you see these structures here. So this is where aqueous humor drains and comes out down to the lacrimal duct. So when these angles either narrow or widen because either the ciliary body is inflamed or any other structures is inflamed, thereby they obstruct the normal drainage of the aqueous humor, then intraocular pressure will rise. Get it? So therefore, the goal of treatment is therefore to either decrease aqueous humor production or increase the drainage of the aqueous humor to maintain normal intraocular pressure. So let's go now to the treatment. Signs and symptoms first. So it's the most common eye problem in North America, worldwide actually. So here are the risk factors. Who gets it? These are the races. It increases with the following diseases. If you have heart disease, which causes hypertension, diabetes, which causes the slow circulation in microvascular structures, like especially the eye. If it runs in your family, pretty much if you have glaucoma in the family, then most likely you also have diabetes and heart disease, correct? Migraine syndromes, myopia, obstructive sleep apnea. So these are the known risk factors that contribute to glaucoma. So if your family history have these, then you are a candidate for glaucoma. So what should you do in order to preserve your vision? You should get regular eye exams. Okay. So it's a simple exam, takes a few minutes. So they measure the pressure inside your eyeball, and then the sooner you get diagnosed, then the sooner you can begin treatment. Then the longer your vision will be preserved. So what is the normal IOP pressure? So it's between 10 and 21 millimeters of mercury. So you have glaucoma once your pressure reaches 22. As I mentioned, there are several types of glaucoma. We have the most common type is the wide-angle glaucoma, narrow-angle glaucoma. There's one emergency here, which is acute narrow-angle glaucoma, which will be mentioned separately. These are the manifestations. So the patients here have no eye pain. So there is no warning. So that's why they call it silent thief of sight. So equivalent to hypertension. Does hypertension also have signs and symptoms? None. Okay. Most people with hypertension have no signs and symptoms unless the blood pressure is already over 200 or even higher. So the patient here may not seek healthcare until they have symptoms, which are now going to be blurred vision, halos around lights, difficulty adjusting eyes in low lighting, etc. And the headache here. The headache already means that the intraocular pressure is high enough to cause the symptom of a headache, which is equivalent to severe high blood pressure. So here are now again the problems that arise. Oh, that didn't help. The one or more of these angles are now blocked, causing a buildup of the aqueous humor volume and therefore intraocular pressure. Here are some descriptions. I won't test this table, 58-4. I will just test you on the manifestations of 2, which are again, which is the most common type? Wide angle glaucoma. That's the only one I'm, one of 2. So wide angle, since it's the most common type. Next is the acute angle closure glaucoma, since this is an ocular emergency. Because again, all emergencies are testable on the NCLEX. So will this definitely be on the NCLEX? Yes, because it says it's an emergency. So these are the manifestations. Rapidly progressive visual impairment. There's pain in the eye. Redness of the conjunctiva. Then the pain will be associated with nausea, vomiting, bradycardia, and sweating. Right? So that's for acute angle closure glaucoma. What do we do again once we see these manifestations or the patient reports them? What's your next action? Okay, notify the ophthalmologist. Okay, because again, it's an emergency. Patient could go blind. And these are the interventions. So the doctors will give you orders on what eye drops or ointments to give, and then they'll perform emergency surgery. That's it, only 2. What are those again? Wide angle glaucoma, and what's the other one? Acute narrow angle glaucoma. Okay, acute angle closure glaucoma. Let's go to the medicines now. Now, as I mentioned earlier, this is the one with the most number of eye medications prescribed. So most patients will have, some will have 2, but I've never seen people with 1. Okay, so it's usually 2 or more. Let's just put it that way. So some patients may have up to 4 of these eye drops. The ones I highlighted, because there are many generics under the same drug class. So under cholinergics, for instance, so I'm only going to use pilocarpine, which is the most commonly prescribed eye drop in the community. So for cholinergics, you have pilocarpine. Now, this is a drug chart. So therefore, what am I testing? And nursing responsibility. It's always the nursing responsibility. What are you as a nurse supposed to do? Okay, what are your responsibilities when giving pilocarpine? Next drug is timolol. John was asking earlier about patients who have hypertension, which is a risk factor for glaucoma. So therefore, they go together. Hypertensive patients who have glaucoma will receive the same treatment. So timolol, please take note that I know this is local eye administration. However, will there be some degree of systemic absorption? Yes, there's always some degree of systemic absorption here. Yeah, and I mean, it's intended to work only in the eye circulation, but of course, it will end up in the general circulation. However, the dose is small, so therefore, you don't really expect a drastic drop in systemic blood pressure. But just keep in mind that there is systemic absorption. So just like any other beta blocker, what will it do to your blood pressure and heart rate? It will decrease. Next, brimonidine. So if you look at the function, as I said earlier, what are the 2 goals of the treatment? 2. What do we do with the aqueous humor? Decrease production or increase drainage, right? So that's what all of these drugs do. So if you go back to pilocarpine, this one increases drainage. What does timolol do? Decrease production. What does brimonidine do? Decrease production. What about acetazolamide? Decrease production. Now, acetazolamide is a diuretic. Again, this is an eye drop though, but you will see IV acetazolamide given to heart failure patients as well. And you have latanoprost and increases outflow of aqueous humor. So how many do I have? 1, 2, 3, 4, 5, right? So 5 eye drops possibly on the exam. Teaching again is on how to administer eye drops, correct? So you go back to the chart on the previous page under, well, it was on this page actually, right? Sorry. It was up here and before glaucoma. Right here, chart 58-5. Okay. As I mentioned earlier, I will not test the surgical options because very few people undergo surgery for glaucoma. 9 out of 10 are on eye drops for life. And here are your teachings for glaucoma. Top of the list would be how to administer eye drops. Because again, how long is the treatment? Lifelong. Okay. Now, it may be okay if you're dealing with because most patients are older, 65 or older are the highest risk for glaucoma. However, what if your patient is a teenager? Will a teenager be very compliant with eye drops? Does applying eye drops look cool or sexy to a teenager? So are they likely to comply? Okay, so that's a challenge for young patients. Plus again, you have to, what would be a common reason for non-compliance here? So imagine yourself with glaucoma. What would be a challenge? Like you're doing this every single day for the rest of your life. What about is it comfortable when you apply eye drops? What happens again? So the tearing, the blinking, the redness of the eye, okay, the irritation, the burning sensation, correct? I mean, who has received eye drops here? For whatever reason, for allergies or for pink eye, it burns, right? Yeah, there's a few seconds wherein, one or 2 seconds wherein it feels like it's burning, correct? And that's again what triggers the tearing, correct? So it's uncomfortable to apply eye drops. And that's it for glaucoma. Any questions? Very good, children. Let's go straight to cataracts. Okay. Now, the eye surgery mentioned here and the pre and post-op care will apply to any other eye surgeries. Are we clear? Okay, so we will just use cataract surgery as an example. But again, the pre and post-op care will apply to any patient undergoing any eye manipulation. Because is it a different eyeball that they're doing surgery on? The same. So therefore, your nursing care will be the same pre and post-op with a very 1 or 2 difference. Okay, we'll mention that later. So what are cataracts? So these are lens opacity or cloudiness. So it's like your windshield in your car got really cloudy and got worse over time. So what do you do if your windshield is now cloudy and no matter how you clean it and wash it, it's now frosted? So what do you do? New car or just a new windshield? Okay, so it's exactly what we're doing here. So the lens in our eyeballs are now cloudy. The reason here is usually age-related, but that's not 100%. So this is what a cataract looks like. This is a very ripe cataract, example here. So this is ample for surgical removal already. But it doesn't always begin like that. So it begins as a small section, only a small part of the eye, and then the opacity extends until the entire lens is involved. And at that point, then the patient can't see anymore. Manifestations, usually no pain involved, just like in cataracts. So the patient will have blurring vision. Can have also double vision and some color changes depending on how bad the lens opacity is. Management, there are no eye drops, ointments that can clean the lens. The only option is surgery. So here, no non-surgical treatment cures cataracts or prevents cataracts. What's the only treatment? Surgery. So surgical removal is the only option with cataracts. However, this section will mention eye drops, okay? Post-op, are we clear? Meaning after surgery, do they need antibiotics? Yes, do they need anti-inflammatories? Okay, so those are the eye drops that will be prescribed after the surgery. But is the purpose of the eye drops to cure the cataract? No, this is just to treat the unpleasant side effects after surgery. Because of course, after surgical manipulation, I don't want to show you a video because I can't stand watching the videos on YouTube on eye surgeries. That is very violent, and I can't help but tear up whenever I see it. But you're welcome to watch it on your own. Okay. More than that. Okay. I'll just describe it later. So cataract removal is a billion-dollar industry. So many patients, especially in my family. So again, we have hypertension, diabetes, heart disease in my family. So my siblings are in their 70s now, and 3 have so far gotten cataracts and had them removed. So I'm a candidate. So someday when I reach that age also, I know I will develop cataracts and will require surgery as well. So it's a very quick surgery, less than an hour, it's done. But the recovery, of course, will take several weeks, and you need to wear protection because after eye surgery, are you certain that you're not going to rub that surgical eye? Because it's going to be itchy, right? It's inflamed. It's going to be swollen. It'll be red and itchy. So are you going to stay awake for 24 hours times 7 to 14 days? No, you have to sleep somehow eventually, correct? So are you certain you won't rub it while you're sleeping? Okay, so that's why we need to protect the surgical eye. So here are the risk factors. Number 1 is aging, but again, it's not exclusively aging. So here are the other possible risk factors for glaucoma. So infection, myopia, retinal injuries, or exposure to toxins. Say you're working with these chemicals at your job. Let's say you or a family member smokes, for instance, etc. All right. So these are the other risk factors for cataracts. I won't test the table 58-6 either. Here's a guideline, and this is usually what doctors or ophthalmologists will follow, that if both eyes have cataracts, the worst eye is treated first. Okay, because why not do both eyes at the same time? Okay, because the patient can't see now, and then the injuries that they could potentially sustain, of course, is a ground for a possible lawsuit, right? So surgeons will refuse to do both eyes at the same time. Let's go now to the, not all patients will have lens replacement. Most will have it, but not all will receive a lens implantation. Because remember, in cataract, it is the lens that became opaque, right? And cloudy. So therefore, the removal is involving the lens. So whether or not to put an artificial lens is up to the ophthalmologist, if the patient is a candidate or not. Okay, so pre-op care, the patient may receive a few eye drops. Again, this will be not again for the cataract, but for the surgical procedure. So antibiotics may be given pre-operatively. Including dilating eye drops. So these are some of the pre-op eye drops, and then post-op especially, of course, will now involve steroids and anti-inflammatories. Okay, definitely we have antibiotics before and as well as dilating eye drops before surgery, and then post-op will continue with the antibiotics and steroids as well. Now, these are there should be a chart for post-op care. Eventually, there will be a chart for the how to care for patients who underwent eye surgery. Okay. Okay, we'll get to that. Where? 50 chart 58.6. Is it above or below? Anyway, so here's the immediate post-op care. The patient will be wearing an eye patch. An eye shield, sorry. So the patient will be wearing an eye shield, especially at night. Okay, for the first week to avoid, again, scratching or rubbing the surgical eye. Then for pain, they'll be given, depending on how bad the pain is. But usually, the pain is mild. Now, if the pain is severe, that's not a good sign. That's usually a sign of increased intraocular pressure or possible retinal detachment, which is mentioned up here under the complications. But again, I'm not testing the complications, but just know that any eye surgery can result in retinal detachment, and cataract surgery is not any better. What chart did you see again? 58 dash what? This one? This one?
The chart you were just at. Yeah, the one you were just at.
Is it a chart or a table? This one?
Yeah.
Then this is complications though. This is not post-op care. Again, there's a chart somewhere, probably on the next page. Is it? Let's see. Page what? Right here? What's the title? This one? No, this is only for the lens implant. Oh, you know what? Yeah, you're right. Okay, sorry. This is the post-op care for eye surgery. So this will apply to any of the eye surgical procedures. Are we clear? Okay. focus on these bullets right here. Say the activity restrictions, let's say lifting weights, driving a car, or contact sports. Should you be doing any of those? No. What will they do? Increase intraocular pressure. Okay. No matter how relaxed you are with driving, is driving stressful? Yes. No matter what city, okay? New York City or even a rural area, right? The rural area, they may not be dealing with traffic, but they could be dealing with drunks. Yeah, drunks, deers, or road rage, right? So here, avoid, so positioning. And let's start with ADLs. So how should you care for the eye? Use a clean tissue each time. When doing hygiene, shampoo hair cautiously because do you want to get the eye wet? So how should you do your shampooing? Well, are you going to like bend over the sink? Because bending over does what to the intraocular pressure? Okay. By the way, which brings us to that topic. What activities would increase intraocular pressure or generally speaking, increase intracranial pressure as well? Yes. Sneezing, what else? Coughing, leaning forward or bending over. What else? Joy? Okay, vasovagal maneuver. So what do these activities have in common? When you're having sex, when you're sneezing, coughing, when you're pushing and pulling, what are you doing really? Holding your breath. So you took a deep breath in and held it. So therefore, what did you do to the venous drainage from the head when both lungs inflate and not deflate because you're holding your breath? Okay, it decreases venous drainage from the head. So there's less blood return coming from the head of the patient. So therefore, it increases intracranial and intraocular pressure. So how do they sleep? Not on the side of the affected eye, okay, because that will decrease drainage. So here are again the activities that will increase intraocular pressure, right? So again, these activities here all do what? How? You are holding your breath, right? Okay, so can you climb stairs or up and down stairs without holding your breath? No. Can you have sexual activity without holding your breath? All right, let's you need some privacy or all right. So what do we report? Okay, so report to the physician the following. Any vision change. Now also tell the patient, will the vision be 100% improved after surgery? No. Not yet. Okay, so remember there's a lot of swelling. So the eye, what will the eye look like? Is it gonna be clear after all the scalpel and the stitch? No, okay, they'll be red, right? So it'll be red and swollen, but the vision should be improved from before surgery. However, tell the patient that the best vision won't be apparent until weeks after the surgery. Okay, so it'll get better every day, but don't expect it to be 100% clear right after the surgery. Okay, so expect it to be again swollen, red, itchy, and a little painful. It should not be severely painful. Are we clear? So there's just mild pain here. So therefore, these are reportable. Vision change, meaning it got worse or better? Well, no, I mean, what do you report? Okay, the vision should not be worse. If it's worse, then you report that. Flashing lights appear. So that's a sign of retinal detachment. Redness, swelling, or increased pain near the eye. Change in the amount. You've all had pink eye. What does the pink eye color look like? The drainage. Anything colorful, right? When we wake up in the morning, do we have sometimes crust at the corner of our eye? Yes, what is that color? White, right? That's usually white or sometimes clear, right? That's normal because that's just from the dirt you were exposed to during the day. As long as it's dry and crusty, it's okay. However, if it's wet and creamy and yellow, orange, green, is that normal? Okay, anything colorful like that is never normal. So that's referring to the change in the amount or type of eye drainage. Yes.
When it's dry and crusty, is it possible to be yellow sometimes?
Yeah, it's okay as long as it's dry though. Yeah. Significant pain, again, not relieved. So minor pain is okay, but significant pain, especially those that don't respond to Tylenol or ibuprofen, that is reportable. Any questions about the post-op teaching? Alrighty. Oh, activities. Sorry. Here, more education. So we told them to wear the eye shield at night, but what eye activities are prohibited? So of course we wear sunglasses when we're outdoors, but what do they, what activities are prohibited? Can you do some sewing hobby? No, stitching or close reading. Okay, because that will cause rapid eye movement, correct? And then causes trauma to the eye. So avoid those as much as possible. No, rest the eye. I mean, you can watch, TV, but not for a long time. So expect vision to be best up to 6 to 12 weeks. Okay, so make sure the patient is realistic about it, that they will not have the best vision until after 6 to 12 weeks. So it's going to be up to how many months? Up to 3 months, okay, before they see the best result. Okay, we have no corneal disorders. Next topic after glaucoma and cataracts is okay, retinal disorders now. Okay, we'll only do retinal detachment as detachments and tears. So with retinal detachment is always caused by trauma. Now the trauma doesn't have to be, you got punched or you fell and hit your head. It can be surgery. Okay, is surgery traumatic? Yes, so that's one of the causes of retinal detachment. So let's look at the picture of the retinal detachment. Okay, so what you're looking at is the eyeball. This layer of tissue here, this yellow part, is supposed to be stuck to the wall of the eyeball. That is the retina. It's supposed to be attached all the way here. There's not. So this is clearly detached, correct? It's like peeling a page on a book. So this one is supposed to be stuck here, like skin. Okay, so that retina is supposed to line the wall of the eyeball. In this case, it's clearly detached. So can you see? No, because light has to be refracted and reflected against the retina before the optic nerve can interpret what you're looking at. Okay, and then the signals will be carried to the brain, and then your brain tells you, oh, I'm looking at Miss Kirko. Oh, I'm looking at Miss Peters' nice shoes. Okay, so it's that's how our eye works. Now, once there's detachment, these are now the manifestations. This was mentioned earlier after cataract surgery, because again, does cataract surgery possibly cause retinal detachment? Yes. So it's like a shade or curtain across the vision of one eye, flashing bright lights or floaters. Okay. Like my father-in-law sustained retinal detachment just by simply hitting his head on he was bending down to pick up something under the desk, and then when he got up, he hit his head on the counter. Then he saw floating these floaters in his right eye, but then he said, no, I don't know what that was. He just ignored it for how long? 10 years. So nobody had an idea that he had retinal detachment. So now he is blind because there's nothing we can do now. So the moment he went to the doctor, it's been years already. Why didn't you say anything? He says, oh, he had no answer for that. Okay, so now he's blind. What should be done when the patient has these manifestations? It is just like the acute angle closure glaucoma, this is a ocular emergency. So what should he have done the moment he hit his head and saw floaters? Go to the ER right away. Okay, it's an ocular emergency. We need to repair the detachment right away. Because if you wait too long, then we can't reattach it anymore. Okay, so there's a chance we can reattach the retina as soon as a few hours or at least 24 hours after the incident. Okay, so here's the management. Surgery. Surgical care again, pre and post-op, any different from cataract? Exactly the same. Okay, so let's start with the first option. So they'll put a scleral buckle. Look at the figure. This is the buckle. They put a silicone strap around the eyeball to reattach the retina. Now imagine, so this is inside your head, correct? So this is your forehead somewhere here, and then your nose is somewhere here. So this is inside your eyeball. Now imagine, how did they put this buckle around the eyeball? So imagine the amount of trauma they will have to do and how many instruments they have to attach to the muscles of the eye in order to manipulate it and then attach this buckle around the eyeball. So imagine the amount of trauma that will, again, there's plenty of videos. If you're interested, go ahead and watch the video. Just type in scleral buckling procedure and it's interesting, okay? I just cannot watch it. Of course, there will, no, not weaken. It will, there will be trauma. So there will be a lot of pain post-op. Because they will attach clamps to about 8 eye muscles in order to, so there'll be, expect 8 clamps so that they can move the eye as they put the buckle around it. Okay, so they'll be tugging here, right? And then vice versa as soon as they put the buckle around the eyeball. So that's one procedure. The other is the vitrectomy. Now, the option in vitrectomy is they'll put a gas bubble or a silicone oil or perfluorocarbon into the eyeball. Now, what are these going to do? These are dense matter. So this gas bubble is a dense bubble. Dense meaning not heavy, but what is the difference between dense and heavy? Yeah, so when we say dense, there's a lot of molecules there, right? But these molecules are light. Okay, so therefore, compared to light gases, which will still go up, a gas bubble will do what? Will a bubble always go down or always go up? A bubble will always go up. Okay, but since this is a dense gas bubble, what it does is, let's go back to the tear. Oh, the detachment, sorry. So if let's say this is the detached area, they'll put the gas bubble. Depends again. The gas bubble option, the vitrectomy will depend on where is the tear. Usually when it's an upper retinal tear, they'll use the gas bubble because it's perfect, because if you put the gas bubble in, where will the gas bubble go? Up, and it will push the retina back into place. Make sense? So that's how it works. Now, it's important if that's the option, that the patient follows the exact instructions of the physician. So let's say the tear is right here of this part of my retina on the left eye, this part here, it tore, it tore up apart. So therefore, when the physician puts the gas bubble, where will the gas bubble go? This way or this way? It go this way. But where do you want the bubble to be? Here or here? I want it here. So how do I move my head in order for the gas to go there? I will lean toward my right. So the gas bubble goes here and pushes against the detached retina. So if the doctor tells you, okay, sleep this way, okay, and then walk around also this way. Well, can they do this? Yeah, of course, if you have to, but you must keep your head in that position as much as possible for it to work. Does that make sense? Okay. Sorry? No. I mean, I know some eye practice surgeons, and no, they just tell the patient, okay, put it this way or put it that way. Okay, out of time. I will, you know what? The macular degeneration is 2 minutes. Okay, let me finish it. Okay, there are two types of macular degeneration. There's a wet and a dry one. The most popular, or no, not most popular, the most common type is the dry type. The dry macular degeneration is age-related. So what's the cause? Age, you got old. So over time, the macula is the center of your retina. That's the macula, okay, responsible for central vision. So what happened is you got old, okay, the macula degenerated, so you're going blind. The manifestations, of course, you're going blind, okay. But unlike glaucoma, which I forgot to mention, in glaucoma, the loss of vision is peripheral first. So the patient will have tunnel vision. This one, the patient will lose what? Since it's the macula that's affected, responsible for central vision. So which vision here will go first? Central vision will go first. There's no cure. We can only preserve what remaining vision you have through eye vitamins. So you can go to Bausch & Lomb, they make AirReds, which are a combination of eye vitamins. That's all the doctor will prescribe. So for dry macular degeneration, what can we do? Vitamins. Okay, give you vitamins. Don't mess with your eye. Try to preserve what's left of it, but they are eventually going to go blind. The other type is treatable. The second type is not age-related at all. This one is caused by, I'm not saying it's cancer, but characteristics of cancer. What happens is the patient in the eyeball grows new, fragile, leaky, abnormal blood vessels. Because these are abnormal blood vessels, again, they leak. They're leaky. So therefore, what do they do to the perfusion of the macula? Because they're leaky. Okay, it leads to decreased blood flow to the macula. Okay, and then therefore it deteriorates. So leads to wet macular degeneration. However, there is treatment here. Since it's caused by these abnormal blood vessels, so what do? Give them drugs to prevent the growth of those abnormal blood vessels. So they use chemotherapy. So chemo drugs are the exact name are some endothelial growth factor inhibitor drug. Okay, so it prevents the growth of these abnormal blood vessels, and that's the treatment for wet macular degeneration. So here, so to stop the leakage of those vessels, they can do laser, or again, there's a drug that they administer, which is like a chemo drug. And that's it for eye disorders.